We will have two sessions again. The first one will be the WFNS Education Symposia number 22, and it will cover the how to examine a spine patient. It looks like it is a very basic thing, but we have still problems with that subject. And I will give the words to moderate the session, Dr. Maurizio Fornari and Dr. Sandeep Vaishya. Please, Maurizio and Sandeep.
So, Mehmet, you are the first speaker, so why don't you start? You share your screen and...
Okay, I can make it. Just a second. Yes. Do you see my screen?
Yes.
Yeah, good. We will start with the back pain differential diagnosis. And I will start by showing you that case, a very simple case actually. This is the 62 years old female patient has got back pain for many years, but for 6 months she says she has right leg pain. And the radiology shows L5S1 ischemic type of listhesis. And the disc height has decreased, and many people would see these films and then would think that the pain is because of this listhetic segment, and would like to make a fixation for this lady. But on examination, she had sacroiliac joint pain. She responded to a test injection very well, and her pain completely relieved by radiofrequency lesion of right sacroiliac joint. So this is a very interesting thing, that seeing a very apparent radiology, but it is not related with the source of pain. The problem, there is a big problem, I believe. Identification of the source of pain in degenerative spinal disorders is difficult, and incidental radiologic pathology and back and leg pain are common. And if we try to classify spinal disorders, most are non-specific, like 85 to 90% of the patients come to you with low back pain, or neck pain, and only 10 to 15% are specific disorders. And the pain is the primary and most important symptom. It's a subjective symptom, and the origins of low back pain are various, not just one. Disc, weak and stretch muscles, lumbosacral ligaments, facet joints. And because of that, we have a bizarre terminology like discogenic pain, myofascial pain, osteogenic pain, facet pain, central pain, radicular pain. This is the terms we use in our daily practice. However, there are mainly two types of pain only. One is the nociceptive pain, the other is neuropathic or central pain. And another concern must be the acute versus chronic pain, which is quite different. In acute pain syndrome, you get good responses to analgesic drugs. However, in chronic pain syndrome, we need a multidisciplinary approach, psychiatric approaches, occupational therapy, exercise programs. We need them. So we have a big question: how to evaluate pain in spinal disorders. We can evaluate first by history taking, then observing physical examination, neurological examination, and then other investigations like radiology. History taking, we must ask the pain characteristics when, during which activities, the period, morning stiffness, and ask the other symptoms, claudication, weakness, sphincter problems, others. And pain characteristics will direct us with if there is a pain with fever and weight loss, infection or neoplasia may be the reason. Pain when lying and at night, tumor. Morning stiffness, rheumatologic disorders as well, discogenic low back pain, and mechanical pain. And we start our examination by observing during walking, because then paraparesis, Parkinson disease, scoliosis, kyphosis may be apparent. And we must also do a neurologic exam. It's very necessary, but not the sole exam, and too much stressed in residency programs. What about differential diagnosis of back pain? In discogenic pain, the pain is more during sitting. Forward bending is painful. Valsalva maneuvers, coughing, sneezing is painful. There is mostly a morning stiffness. The patient tells that when they wake up or get up in the morning, they have more pain, and after a while, it diminishes. And abnormal body posture is quite often. Physical exam, we must palpate the painful area to see the trigger points, sacroiliac joint pain, and let the patient flex and extend the body, and passive movements of the neck and back will be helpful. Lhermitte sign, especially in extension, will show you spinal cord symptoms. And similarly, back extension, if there is a leg pain or numbness, this is similar to Lhermitte sign. If you suspect sacroiliac pain, palpation of the joint is painful. Pain is asymmetric mostly, going down to the hip. Mostly don't go down to the knee area. And sacroiliac joint pain provocation tests are positive. Some reports say it is the source of back pain in 25% of all back pains. These are the sacroiliac joint provocation tests, the Ganslin tests, and the others. But more useful is that the sacroiliac joint injection with local anesthetic, if there is more than 50% pain relief, then this patient would benefit from a sacroiliac joint intervention. And the diagnosis is correct. What about facet pain and lumbar spine stenosis? Sitting is comfortable, standing more painful than walking. Extension and rotation of the back is painful, and forward bending is comfortable. This is very against the discogenic pain. Flexion body posture and kyphotic posture is quite common, and they are more comfortable when they bend forward. What about acute back pain? Mostly after intense exercise or heavy lifting, and sitting and standing are painful, flexion is painful, and trigger points may be found in such acute back pain attacks. Most of the time they heal in 1 to 3 weeks. If it, however, resists after a month especially, then you can ask for some other tests. What about chronic back pain? If any pain resists after 3 months with intense pain, then some additional symptoms develop, like psychological effects, depression, such pain do not respond to normal painkillers. An additional neuropathic component is apparent, and mobilization exercise program can be more beneficial than bed rest in chronic pain patients. And a multidisciplinary approach is necessary. What about differential diagnosis? Radiology, electrophysiology, as you know, today's medicine is by ordering too much radiology. It happens, especially in my country, that we are having a world record of getting lumbar MR images in back pain patients. Do you order MR in all low back pain patients? If there are red flags, yes. And I will not tell more details about this, but if the new onset pain in a patient with known previous malignancy, if weight loss, loss of appetite, fever accompany the pain, if new onset pain after the age of 60, if serious neurologic findings accompany, if pain intensity did not decrease after 4 weeks, if pain does not decrease during rest, these patients must have MR image or other investigations. Best test is MR in diagnosing of back pain. However, there is almost no correlation with radiology and degenerative spine symptoms. And we know that radiologists report lumbar disc herniation in 25% of normal population. And today's, I criticize today's medicine that the patients are having low back pain, and the radiology is ordered, and disc herniation is reported, and a surgery was done because disc herniation was reported. So then no pain relief. So such a cascade is not good. Because of that, we must use the sentence to operate the patient, not the films, always. This is estimated number of MR images in the United States only, 3.8 million MR images because of back pain only. Because of that, there is a very nice study who has looked if immediate MR image was ordered or not. If the immediate lumbar MR imaging will help the prognosis of those patients. However, they have found that not imaging patients with acute low back pain will reduce harms and costs without affecting clinical outcomes, and it's not necessary. What about value of other diagnostic tests, especially the electrophysiology? Somebody may ask very often electrophysiologic tests, although it's not much related with back pain, but in sciatic pain or other radiculopathies, the fact is there is no good test measuring pain, type, or intensity, and electrophysiology results depend on what tests you are doing, and EMG and nerve conduction study must be done in case polyneuropathy possibility, ALS possibility, cauda equina syndrome, foot drop without pain, and follow-up of a foot drop patient if it is regenerating or not. If there are symmetrical sensory deficits, neuropathic pain more intense than somatic pain, pain during rest, symmetrical deep tendon reflex losses, motor loss without pain, atrophy is more prominent, and symmetrical paresis and fasciculations. In those cases, we must order EMG or nerve conduction velocity. However, lumbar disc herniation, cervical disc herniation, cervical myelopathy, and lumbar spinal stenosis patients with neurogenic claudication it's not necessary to order EMG and neuroconduction study, and their value is always questioned in such conditions, especially in radiculopathy patients. So I will skip those slides, and I will come that conclusion. Pain is the main problem in degenerative spinal disorders. Its evaluation is not easy, and pain is polluted by many factors. And most of the spinal disorders are non-specific with mechanical low back and neck pain. We must not forget operate the patient, not the films, the sentence. And seniors must make clinic and patient evaluation with juniors. I want to invite you to look at the website of WFNS Education Committee. We have a previous webinars there. All online symposia are there. This is like this. The web page looks like this. And there are also spine webinars there where you can observe and listen and get advantage of that. Thank you for listening to me.
But you made a very important point. Like in this era of MRIs, the art of examining the patient is getting lost. And one must